Hi, everybody. Welcome to What's Up with That Cornea. I am Dr. Kenzie Coyne, and I will be your host. Our episode today takes place in the Johns Hopkins Wilmer Eye Institute. Let's meet our patient. Our patient is a 61-year-old Caucasian female presenting with complaints of blurry vision with constant aggravating dryness in both eyes. She has quite an extensive ocular history, including a retinal detachment in the right eye that was treated with a scleral buckle and cryotherapy, a cataract extraction with IOLs in both eyes. She also had a tilted IOL that needed to be repositioned in the left eye, YAG capsulotomies in both eyes. She also has a history of ocular rosacea and frequent severe recurrent corneal erosions. In terms of her medical history, she also has osteoporosis, for which she takes abangonate, and hypertension, for which she takes losartan. When this patient presented to us, she had 20/60-1 vision in the right eye and 20/50-2 vision in the left eye with glasses. She had normal pupils and EOM function. However, on confrontation visual fields, she did have a superior nasal constriction in the right eye due to her previous retinal detachment history. I bet you're curious what her eyes looked like, so let me show you some photos. We'll start with her corneal topographies first. This is the right eye's corneal topography. Take a moment to look over the scan and evaluate. This is the left eye's corneal topography. Try to take a guess of what you believe might be going on here. Now, here is an anterior segment photo of her right eye. Does this align with what you expected based off of her corneal topography? Here is a photo of her left eye. It shows similar findings to the right eye. So what do you think? It's time to place your final bets. Do you have a differential diagnosis? What's up with that cornea? If you guessed Salzmann's nodular degeneration, you would be correct. Let's talk more about what Salzmann's degeneration is. Salzmann's nodular degeneration is a progressive condition that results in the formation of nodules that are located histologically between Bowman's membrane and the corneal epithelium. As you saw in the previous photos, they typically have a bluish-white color and may have associated neovascularization. Although the exact mechanism is not fully understood, Salzmann's nodular degeneration has been hypothesized to result from the chronic inflammation of the ocular surface. This chronic inflammation leads to the activation of keratocytes, which leads to the migration of stromal fibroblasts that further differentiate into myofibroblasts. This ultimately leads to the production of a fibrotic and disordered extracellular matrix in that area. Examples of chronic mechanical irritation of the epithelial surface includes recalcitrant dry eye disease, ocular surgery, and contact lens wear. Sex hormones are also thought to play a role in the pathogenesis of the condition due to their impact on tear film production and composition. Salzmann's nodular degeneration is commonly seen in middle-aged females, similar to our patient. This patient checks off a box in each of these categories. She is a 61-year-old female with extensive history of ocular rosacea and ocular surface disease. She also reports a history of corneal RGP wear and has had several ocular procedures in her lifetime. These nodules are a problem because they induce irregular astigmatism, scarring, and tear film abnormalities that can result in poor vision and ocular comfort. So, what's up with that cornea, and how are we going to fix it? Looking at these scans, we can see that this patient has irregular astigmatism with a distorted and asymmetrical corneal surface. I would argue that scleral lenses are the best option for this case for a few reasons. We want to avoid further mechanical irritation of the epithelial surface. Corneal GPs or hybrid lenses could potentially rub and irritate the elevated mid-peripheral corneal nodules and further exacerbate the condition. In comparison, an oblate-shaped scleral lens would vault the cornea and avoid these mid-peripheral islands of elevation. The patient also has ocular surface disease that can be managed through scleral lens wear. A larger diameter scleral lens will be able to better hold lubrication over the bumpy front surface of the eye and avoid focal areas of desiccation. Ultimately, we fit this patient into a 17mm diameter oblate scleral lens. With an over-refraction, we were able to achieve 20/30 vision in the right eye, which was the eye with the previous retinal detachment, and 20/20 in the left eye. The patient immediately felt relief from her dryness with the diagnostic lenses in and even wanted to leave with them that same day. The power of contact lenses is amazing. Thank you for tuning in to today's episode of What's Up with That Cornea.